organization, and I'm going to talk to you about what that job involves, a bit about my background, how I got into coding, what my education background is, how you can get into clinical coding, on what my sort of average day looks like in this job. And then obviously we're happy to take some questions as well at the end. So clinical coding is where we look at the patient's journey when they come into the hospital. So from the time they come through the doors of the hospital to the time they leave, and that could be an attendance for a day case operation, or it could be that they've come in because they're not well, so they've come in through A&E, for example, and then had to stay for maybe a week, 2 days, 3 days. And what we do is we look through the information. Obviously, this trust, we have case notes, but we also have electronic information. So it's a combination of the two pieces of information that we look at to find out what happened to that patient during their journey in the hospital. And then what we do is we collate that and use an international system, and it's called the International Classification of Diseases. It's a World Health Organization publication to attach alphanumeric codes to the episode of care. So say the patients come in and they're not feeling well, and the doctors found that their blood pressure is raised. So high blood pressure is known as hypertension. So what we do is then we look up that information in the ICD-10. That's the diagnosis for that patient, and it's the code that we utilize is I10X, and that describes that patient's diagnosis as having hypertension. So we also then look at the information, like I said, from the systems and from the case notes to see what was done to the patient. Were they given any medication, or were they just stayed for a day, and once blood pressure had come down, they were sent home. So the other example would be where a patient has come in, they've injured their hand because they fell off a bicycle, for example. What I'll be looking to see is how did that patient fall, what were the circumstances of that injury, and what was done. So in that example, for example, they would have had said they have got a fracture of the bone in the hand, and what would happen is that they've gone on then and had an X-ray done to find out exactly where that fracture is, and then the doctors decided, well, we need to operate on that fracture and do what they call an open reduction with an internal fixation, and that just means they need to open up the part where the bone is fractured and attach a fixation device, and that basically what that does is hold the bone fracture site together and will allow healing of that fracture. So what I'm looking for here is the site of the fracture, how that patient felt, the circumstances, and how they fixed the fracture. And what that does is, again, utilizing the ICD-10 would give me the actual code for the fracture. So that would be, say, S62.60, for example. And then how they went on and actually repaired that fracture. And for that, we utilize what we call the OPCS. And that's the procedural code. So we've got the diagnostic codes on one hand, and then you've got the procedural codes on the other hand. And what that provides is a healthcare resource grouper, and that brings in a payment for that patient for the work that was done in the hospital. In addition, the information that we then put onto our systems using an encoder is sent off, and that informs what they call healthcare episode statistics. And that's utilized for many, many reasons. So for planning of resources in a hospital, in a region at government level, epidemiological purposes, for audit purposes, and for, like, say, healthcare resource planning purposes. So, for example, they would need to know how many consultants do we need in this hospital? Has the activity gone up? Are more people falling? And if so, where does the government need to put the money? So these statistics are really, really important, the work that we do. So at the moment, obviously, we're in the middle of a pandemic, COVID-19. And you probably hear on the news a lot about so many patients at this hospital, or the numbers are going up, the attendances are on the rise, A&Es are busy. So that some of that information comes from us, the coding information that we provide. So when the pandemic hit, the World Health Organization released some emergency codes, and those codes describe the so when you get COVID-19, they describe the fact that you've got the infection. They also describe the fact that you've got long COVID. So if you've got COVID-19, the code that we use is U07.1, and that describes that this patient has got COVID-19. In addition, they can come back at a separate time, because now they've got COVID-19, they've recovered, but then they've still got an ongoing cough, for example, and the doctor said that's a sign of long COVID, which you probably hear a lot about these days. And again, we have a different code that describes that. It's another U07 code, but that describes long COVID. And again, that information, we that's an ICD-10 code, and that we obviously import into the system. And that obviously informs many different types of statistics. In addition, obviously a lot of people now have had their COVID-19 vaccination. The other thing we can do is describe the fact that the patient has had the vaccination, but then they've had a side effect from that vaccination. So for example, they've come in, had the vaccine, say for example 3 days ago, and they've got an ongoing headache, or they've got a sore arm, or any other side effect. Now we can use a different U07 code to describe that side effect. And again, that informs those statistics that I mentioned to you earlier. What was my background? A little bit about my background. So I'm actually a graduate. I got a degree a bachelor's degree in biomedical sciences. I went on then trained as a clinical scientist in genetics. So I worked at St. Mary's Hospital in Manchester for many years as a clinical cytogeneticist. But then I decided I wanted to change my career, so this was a career change for me. So I came into clinical coding. For clinical coding, you need to have good GCSEs. So, for example, math, science, IT would be good. An interest in data science would be good. And also, you need some good A levels as well. And again, an interest in IT. What's also really important is that you need to have an interest and understanding of medical terminology. So the reason I said that is because a lot of the information we read in the case notes or on the electronic systems, there's a lot of use of medical terminology, as you can imagine, because we work in a hospital. A lot of us are based in the hospital setting, so we read a lot of medical terminology. For example, a patient has come in, 15-year-old, for example, they've come in, they've got abdominal pain. The abdominal pain hasn't gone away. So, they came in for a day, but they got sent home. So they come back again. The abdominal pain still hasn't gone away. So what they've done is done an ultrasound scan, and that has shown that they've got gallstones. So the gallstones are the actual cause of the pain. So on the first admission, we wouldn't, for example, we would code the abdominal pain because we don't know specifically what's wrong with that patient. But in terms of the money that brings in, it wouldn't be as much, because that's a symptom, what we call a symptom code. And what we need is a more accurate information. So when that patient's coming for the second time at the hospital and they found the gallstones, that's a more accurate diagnosis, and we know the exact reason for that pain, and that's what we're looking for in the notes. And then obviously, the patient is then booked in for an elective gallbladder removal. And obviously that would then ease those symptoms and remove the gallstones as well. So the way they do that is what they call laparoscopic cholecystectomy. That's how it would be written in the notes. Now, laparoscopic means using an endoscope, and the endoscope is obviously put into the abdomen. The cystectomy means a removal, and the cholecyst is the gallbladder. So it's understanding the medical terminology, and you'll see a lot of it. So it's quite important to have an understanding of medical terminology, have an interest in medicine in general, and then we see so many different types of information, and then once, as I said, the gallbladder's been taken out, it'll go for histology, and that would then confirm that the gallstones were found in the gallbladder. So we then go on and look into this different system for the histopathology system, and confirm that diagnosis by looking at the pathology results. So we have to use various different systems. So obviously there I mentioned pathology system, I mentioned the X-ray, ultrasound. We also look at the gastroenterology systems. That basically means when people, so somebody's coming in, and again, they've got abdominal pain, an endoscopy is booked. It's called a gastroscopy. Basically means gastro means your stomach, oscopy means using an endoscope to look at your stomach. So gastroscopy. And what they do is put a camera down into your stomach, and what they found is gastritis. So that basically means the patient's got inflammation of the stomach. Again, that has a specific code. It's K29.7 code. And the gastroscopy, we code that as a G45.9 with a Z27.4. The first code there is the G code, describes that it's an endoscopy to the stomach. The Z27.2 or the Z27.4 describes either it's gone to the stomach or the endoscope has gone to the duodenum. And that's what those codes describe, and that gives an accurate description of what was done to that patient when they came for the endoscopy. As I mentioned earlier, these bring different tariffs in. So I'll give you some examples, for example. So these tariffs are not actually up to date at the moment, but it gives you an idea. So the patient comes in for an exploration of the mastoid. That brings something like a tariff of about £2,000. A full dental clearance, for example, you're looking at about 600 odd pounds. These are the tariffs attached to some of the, some of the work that's done when a patient comes in. I can hear some background noise. I don't know. And then, operations on the nose, for example, a biopsy of the lesion of the maxillary antrum. That's, it's an E13.4 code, and that's going to bring something like, 1,100 to 1,200 pounds. But I was mentioning the accuracy of the diagnosis. So what's important is to look at the exact cause of the patient's stay. So, for example, they come in with a cough, and the coughing up sputum, etc. So that's known as a chest infection, or the doctor will call it chest infection. But if it's not very specific, then that can bring a tariff of, say, £500. But if then more tests are done and it's found they've actually got pneumonia, then that's going to bring a tariff of something like £1,500. So it's really important that accuracy is vital, that we look at the specifics of the information, try and get down to the bottom, why the patient stayed, what was done, why it was done. And so as part of that, and part of our job is to liaise with clinicians. So we work very closely with doctors, with the surgeons here, and with the administrative team and the nursing team as well, to try and get as much information as we can regarding the stay for that individual patient. So a lot of clinical engagement work comes within the role, and that's really interesting. Getting involved with the intricacies of the patient's illnesses and why they stayed in the hospital, and how we can improve the information. So the other part of clinical engagement is how can we improve the information that we get from the clinicians, that whether it be electronic or in the case notes, can they give us more accurate information, and therefore the accuracy of our coding would obviously be much, much higher, and that would make a huge difference. In terms of my average day, so basically I come in the morning, and then obviously I have a workload or for a particular day, and that can involve various different specialties. I've always mentioned a couple there. So you've got endoscopy. We also do vascular surgery. We do gynecology. We do obstetrics. We do medicine. I'm just trying to look at my list here to give you some examples, because we do that many. We do pain. So people come in with back pain because they've got like say a lumbar disc prolapse, so they've got lower back pain, so they come in for pain injections. So these are day cases. Obviously, trauma and orthopedics, which I mentioned to you, so they've got a fracture, so they come in for repair of that fracture, or they can come for a joint replacement. We code those as well. So patients under the urology specialty come in for, say, bladder cancer, so they come in for chemotherapy because of the bladder cancer. General surgery, we can have people that come in with hernias. They can come in, with various of the repairs that are done to the upper GI system. And then we've also got ophthalmology, and that's looking at patients, for example, that have got cataracts. So the elderly patients have cataracts, and they come in as day case to have the cataracts removed, or they can have glaucoma. And with the glaucoma, what they do is they obviously release the pressure at the back of the eye, and that's done as a day case. So we also code those. What else was I going to mention now? So in terms of the work, so we basically go through a daily list, and that's can involve case notes, or it can be electronic information. And then the other part of my day could be phoning up a consultant to find out why there's, get more accurate information on a patient who we know has had a fracture, but it's not very clear as to where the site of that fracture is. So the best thing to do is obviously send an email to the consultant, or try and arrange a meeting to get more accurate information. And in the afternoon, there may be some mandatory training to do as well, which is really, really important. And also we are audited on a yearly basis. So all our work, 50 cases are checked by an independent auditor, and that gives them a validation of your work, really, to see how accurate your coding is. And also we have training sessions every so often on different specialties. And as I say, these books are updated every year, so new codes come in. As I mentioned to you, we've got obviously the ICD-10, which is the diagnostic codes, and that's a World Health Organization publication. So what we need is national standards in the United Kingdom to apply to the ICD-10, because it's international, so we have to have specific standards that are utilized with the ICD-10 diagnostic codes, which are really, really important to be able to understand those. And what else was I going to mention? Have I missed anything there, Melissa? Do I need to say anything else?
No, you spoke about the salary bracket.
Yeah, so yeah, absolutely. Yeah, I was coming on to that. I'm glad you reminded me. Yeah, just so in terms of salary, so as a band 4, you could either come in as an apprentice. There are a lot of apprentice roles out there, or you can come in on a band 4 or a band 3. Band 4, basically what happens is the in-house training team will train you up on the job. And then after 2 years, you can take the ACC exam, and that's the accreditation exam. That means you can then work either independently. You can go and work for an agency, or work for yourself, or set up your own company, which many people have. Or alternatively, you can work in the NHS. And once you've got your ACC accreditation exam, then you go on to a band 5. So do you want me to go through what the bands are, Militia, or would that be enough to say the band 4 and band 5? Do you want me to kind of?
That'd be enough. It's just where they start.
Yeah, just give me a second. Yeah, I'll pull that up. So on a band 4, just give me a second. I'll have a look here for you. But before I do that, if you decided to go and work for an agency, the current rates are, once you're accredited and qualified, they start like from £250 a day, and those are the agency rates. And obviously, if the job is sort of down south, then it can be substantially more, and then they can offer you accommodation as well. So then you're obviously working for an agency, or like I say, you can set up your own company, and then potentially take a whole year's contract, or do 6 months, and then take 6 months off if you wish. It's entirely up to yourselves. So let me just have a look for you on the current salary. They've just actually only gone up April this year. So, for example, on a band 4, it would start at 22,549, and that goes all the way up to 24,882. Once you qualified, you hit band 5, and that's at 25,655. And then after 4 years, it goes up to 31,500. If you want to go into sort of management, or become a trainer, or become an auditor, or become a team leader, for example, then you can go into band 6. That's the next level up, and that's sort of 32,000 to 39,000. So that's your band 6. You can become a clinical coding manager, and that's band 7. So that's 40 to 45,000 pounds. Those are the salary scales. Is that okay? Is anybody got any questions, Militia?
No, not that's on the chat. Has anyone got any questions? What would you say? This is not a question from no one, it's just from me. What was your hardest challenge while being a clinical coding?
I think the hardest challenge is actually passing that exam.
That was
so
hard.
yeah, that's very hard. The ACC exam, it requires a 90% pass mark, and you're given case studies, and there's a theory aspect. It's 6-hour exam, 3 hours in the morning, 3 in the afternoon on the same day.
Wow, so it's a long day.
It's a very long day. Yeah, it is a long day, and I mean, I've done a degree, but like I say, I don't think I've faced an exam quite as hard as the ACC. And we've got people here that've been trying to do it for years. It took me 3 attempts. I got it on the 3rd, I think. So I got the theory on the first go, but the practical is quite difficult. So you got 2 years to do the practical. If you fail the practical, then you could do it within 2 years. If you don't, then you have to sit the whole thing again. So the practical and the theory. But you get scenarios given, so it's like reading through exact case notes. Patient comes in, etc., and you used to use the standards that come out every year in your OPCS and your ICD-10, and then just work through the scenarios. And like I said, by the end of the 6 hours, you're pretty tired, pretty mentally exhausted. But yeah, so the theory covers everything around clinical coding, the history, what the standards mean. They can test you on the standards. Medical terminology, absolutely vital. So, what does cholecystectomy mean? What is a hysterectomy, and etc. And then you're given some pathology. You have to understand what that pathology means. So, the patients had a biopsy taken, for example, on a gastroscopy, and the biopsy has come back and it showed duodenitis as well as esophagitis. So those things means that the duodenitis means the duo means the duodenum, itis means inflammation. So they've got inflammation of the duodenum. Esophagitis means it's the which is the esophagus. Itis again means inflammation. So they've got inflammation of the esophagus and inflammation of the duodenum, and that would explain some of their symptoms. So they're suffering from reflux, so for example, and it's and that gives an accurate diagnosis for that patient. And what they'll do is they start them on omeprazole or something, or some PPIs to reduce the reflux, for example, and then review them again after a couple of months, and maybe do another gastroscopy, see if that's cleared up. Or they can potentially have what's called H. pylori infection, which is infection in the stomach, and that can give some pretty horrible symptoms as well. And again, there's a line of treatment for that, for H. pylori. But again, that's also picked up on a gastroscopy, and we get to see that. Also, we can deal with some quite distressing cases as well. Patients do die when they come into hospital, and you've got to be able to read all that information in the case notes, and that can be quite sad. After it can be for a day, 2 days, and then they pass away. COVID-19 obviously has been very challenging for us, because we've had to read all that, and many patients have died because of COVID-19. So you've got to be able to read that information and code it. And there's plenty of support as well in the NHS. I'm also, additionally, I'm a staff network chair, so I work with the Black, Asian, minority and ethnic staff here at Rochelle Care Organisation. So I support the staff, and I have done over the pandemic. That's another part of my role. as well as senior clinical coder. That's something else I do. So you can take an interest in other things. You know, it depends what you want to do, how much time you want to spend. But the NHS is a great place to work. So I certainly would suggest that if anybody wants to consider this as a career. And the other thing is it can be a stepping stone into medicine. We've had staff that have come in, quite young staff from college, and they've done a year in clinical coding, and then that's inspired them to go and do medicine. Because you learn so much through the information you pick up and the colleagues you meet and what you learn that it actually inspires you to do medicine or pharmacy or whatever. So that's another route. Or you can go into informatics and data management, become a bioinformatician, for example. So there's or you can go into management. There's various things that you can do. And it's not a be all end all really. And it's a very interesting job. It depends, and then certainly what I would suggest is to look at online something called Stepping into the NHS. I don't know if anybody's had a look at that. So if you Google Stepping into the NHS and type in clinical coding, there's a lot more about this career and many others as well on there. The 350 careers in the NHS. It's quite surprising, really. Hope that's okay.
Yeah, that's fine. Mohammed, is there any questions? No? No, I think that's all, Mohammed.
Okay.
Obviously, this is our last one for Oldham College, but next week will be Hotwood Hall, where the invites have already gone out. So it'll be the same time, it's just that Hotwood Hall will be hosting next week's one. Well, thank you, Mohammed, for hosting this. It was very interesting.
Thank you.
And thank you, everyone, for attending. I know we're a bit early, we finished a bit early, but Mohammed said what he needed to say. Take care, everyone.
Take care. Cheers now. Bye. Bye.